Hi, I'm Jeff Dusek, Director of Outcomes Research at the Susan Samueli Integrative Health Institute at UC Irvine. Today I'll talk to you about acupuncture in the ED for pain management, a BraveNet multicenter feasibility study called Acuity, funded by the NCCIH of the NIH. Acuity had three recruiting centers: University Hospitals Case Western, UCSD, and Vanderbilt University Medical Center. Einstein College of Medicine was data coordinating center. There are three aims of Acuity. Today I'll talk to you about the feasibility RCT in the three EDs. Acupuncture was compared to usual care. It was administered in the ED. Outcomes were assessed pre and post about 60 minutes later, and a follow-up assessment at 1 week post-ED visit. Recruitment, retention, and adherence to the acupuncture manualized protocol are the measure of our success. I won't speak too much about the adherence to the acupuncture protocol, but that is a whole different talk. We were looking at adults, folks who could speak English, levels 3, 4, and 5 on the triage reading scale, and a variety of musculoskeletal or back pain or pelvic or non-cardiac pain conditions. Exclusion included fever, psychological issues, migraine, pregnancy, opioid medications taken within 4 hours, chief complaint of dislocation of joints, bone fracture, or confirmed or suspected COVID-19, as the study took place between 2020 and 2022. Acuity study flow was pretty straightforward. Patients were admitted to ED. They were triaged by the study staff using the EPIC medical record. Individuals on our study team would look to see if individuals would meet criteria. As the patient's being roomed, a provider would go then to that room to ensure there was no issue that demanded acute medical attention. If the ability of the patient to participate in a study for an hour was appropriate, our study staff would complete the screening. They would consent them, complete the baseline questionnaires, including a patient-reported outcome data collected on a tablet so we couldn't see the scores. The patients were randomized to either acupuncture or usual care. Those things happened. The study staff went back to the patient at 60 minutes or so and then collected that blinded data on the tablet. And the patients were then put back into usual care, and they were discharged according to their provider. Recruitment varied across sites. It was 28% of those approached were actually enrolled at UH. At Vanderbilt, it was 16%. At UCSD, it was 49%. And across the study, it was 26.1 on average. This is a very busy slide here, but just to point out some things I want to have you see in this slide here. 57% people were females that participated. The age was 44.4 on average, with standard deviation of 17.1. We had a large African American population that participated. This is very rare in these kind of studies, so we were very happy with that participation rate. And we had individuals who were not very well educated, 35%. Individuals who were lower on the socioeconomic rating scale, namely they had a whole family of income less than $50,000, which is about 52%. And then a large number of individuals, their insurance was Medicaid. Location of pain was a variety, which we wanted because that's very indicative of what happens in the ED. 18% had primary pain in the abdomen, 34% in the low back, and 25% in extremities, including hands, feet, etc. And 24% of individuals in the study had an overall prior experience of acupuncture at 24%. I'm not going to speak too much about the acupuncture fidelity, but suffice to say that 98% of the acupuncture sessions were in accordance with the protocol, which did vary by the location of pain. So if there was headache or there was joint pain or was low back pain, the acupuncture points that were recommended and suggested differed. Now the retention rate is very important because we have to retain individuals in the study. So you can see right here at pre-scores, we're perfect at university hospitals and almost perfect at Vanderbilt. There was a little glitch in the blinded tablet where there was an issue with our red cap survey. So that was caught early in the study. So that was rectified, but that did influence the UCSD site. But overall, we had a 91.5% post-score retention rate across the sites. The retention rate at 1 week, let me get to that, was a little bit less, 77.6%. Pain intensity. So you can see here on this slide The pre-score for acupuncture was 8 with a standard deviation of 2.1 at university hospitals. The individuals that were in usual care were 8.1. A little lower pain at the Vanderbilt site for some reason. And the UCSD site, there was a slight numeric difference in the acupuncture group in UCSD, but overall across sites there was no difference. You can see the overall enrollment at the 3 sites where people had pre and post scores varied a little bit across sites. Now, the interesting thing was when we looked to the post scores, we're seeing on average, the acupuncture group went from 7.4 to 4.8, whereas the usual care group went from 7.1 to 6.4, which is a 2.6 difference for acupuncture and a 0.7 difference for usual care. Because it was a feasibility study, the NCCH did not allow us to do any kind of comparisons. This is in prep, we're preparing for a UG3, UH3 definitive study. So really the goal of the study was to block and tackle, could recruit, retain, and then collect the data as we had planned. So the main summaries of this was, again, this happened during COVID-19, so our recruitment rate was 26.1%. 80% of subjects were African American at one site. 45% American of individuals were Hispanic at site 3, and low income and public insurance were enrolled at a high rate, which was very rare. The post-treatment retention rate was 91.5%. 1 week is 78%. Adverse events were very low. There were 2 serious adverse events that were not linked to acupuncture in the study. There were a lot of minor and expected adverse events, namely continuation of pain by the participant. And acupuncture intervention didn't talk too much about that, but suffice to say that 99% of the acupuncture aligned with the protocol. So overall, we're really well prepared for the framework for a definitive study, a UG3, UH3, that will take place across 5 sites, we hope, with about 800 participants. And it'll be a superiority study comparing acupuncture to usual care in 5 EDs associated with Brave Neck clinics. Thank you for your attention. I should note that any kind of multi-site research requires a large team. Here's the University Hospitals Case Western team. That's where I was when I was PI of the study. Now I'm at UCI, Albert Einstein, Vanderbilt, UC San Diego. My co-MPI is Dr. Diane McKee, and then we had a monitoring committee that helped to monitor the study for safety, and an acupuncture expert, Dr. Arya Nielsen. Thank you for your attention, and have a great day.